Hi, Dr. Margaret Ferrante here with Dr. Boyle's treatment of mitochondrial-related functional and dysautonomic associated symptoms, diet, exercise, and cofactors, which are vitamins. Fasting avoidance in the emergency room. Upon arrival in an emergency department with fasting or significant illness, an IV should be placed immediately in D10 containing IV fluids given at 1.5 to 2 times the usual rate. D is for dextrose or sugar, and 10 is for 10%. For grown-ups, we usually will see D5 or 5% dextrose being given. The usual amount of saline salt should be given. Adults usually can take normal saline. Or if you've had a lot of diarrhea or vomiting, some doctors may want to give you lactated Ringer solution instead. Once D10 is running, the patient is no longer fasting because you've got a constant supply of sugar going on. Fasting avoidance prior to medical procedures. The same regimen of D10 containing IV fluid should also be used upon fasting for medical procedures. In most patients undergoing simple procedures, the patient can take the usual diet on the day prior to the procedure, be made NPO, nothing per os, it's Latin, that night at the usual time for their age, and come in the early morning, 6 to 7 a.m. to have an IV placed. D10 with appropriate electrolytes at maintenance should then run continuously before, during, and after the procedure until the patient is able to tolerate enteral feedings or feedings by mouth. Usually the patient can then be discharged home. It is important for the surgeon and anesthesiologist to be aware that there's an increased risk for some complications, including apnea, parentheses, central and obstructive, end parentheses, hypo and hyperventilation, airway hypotonia, seizures, dysautonomia, cardiomyopathy, renal tubular acidosis, and malignant hyperthermia. However, with the appropriate precautions, procedures can be safely performed in most patients with mitochondrial disease. After 24 to 48 hours on D10, protein must be given or fasting for protein will occur. Food, formula, and IV amino acids, parentheses TPN/PPN, end parentheses, are options. Those are the total parenteral nutrition, the white stuff that goes into the neck vein to provide nutrition, or sometimes goes under the clavicle to provide nutrition. If using TPN/PPN, aim at 1.5 grams of protein per kilogram per day. Other dietary factors. Some patients report clinical improvement with a change in the fat content of the diet. A relatively low-fat, high-carbohydrate diet, about 25% of calories from fat, can be helpful with symptoms related to poor motility of the stomach and intestines. Occasionally, a high-fat diet is helpful in patients with mitochondrial dysfunction. For patients with hypoglycemia, a low-glycemic diabetic diet and frequent feedings can often make a big difference.
It's 10 o'clock.
Rare patients are sensitive to fructose, fruit sugar found in many foods, in parentheses, gluten, other proteins, sulfite, or nitrites, parentheses, food preservatives that can trigger migraines, end parentheses, or other substances, caffeine. Although a drug, caffeine is discussed here because it is present in many foods. Caffeine can be a safe and effective treatment for migraine, muscle cramps, and other types of chronic pain. The effective dosage varies by age, size, and person, but generally is about 15 to 60 milligrams per dose in those not already tolerant of caffeine. However, caffeine withdrawal can trigger migraine and other types of chronic pain, so use with caution. Small children usually tolerate caffeine well, and it is safe. Approximate typical caffeine contents of some typical drinks are colas, 30 milligrams per can, Mountain Dew, 50 milligrams per can, coffee, 100 milligrams per cup. Tea varies widely. Exercise. Exercise is important to keep up stamina and muscle mass. More exercise will cause the formation of more mitochondria, providing more ability to make energy and allowing patients to be able to accomplish the same tasks more easily. However, excessive exercise can precipitate symptomatology, including worsening dysautonomia, prolonged fatigue, and muscle pain. Participants should monitor both the intensity and the duration of their exercise sessions. Because of the risk for prolonged dysautonomia after vigorous exercise, I recommend a moderate intensity of exercise where the patient can talk comfortably while participating. With respect to exercise session duration, exercise to exhaustion is not suggested. Whether it be during an aerobics class or lifting a weight too many times on a machine, this has also been associated with dysautonomia. It may take a few exercise sessions to find the perfect balance of intensity and duration that is comfortable for the patient. Just as with anyone beginning an exercise program, seek your physician's guidance first, and starting slowly is the key. What is also important in these patients, however, is remembering the importance of energy balance during physical activity. A good way to remain in energy balance during all types of exercise is to replace fluids and calories by sipping a carbohydrate replacement beverage. After exercise, a combination carbohydrate and protein replacement beverage, such as chocolate milk, is often used by athletes to replenish fuel stores and is highly recommended for those with mitochondrial-related functional and dysautonomic disorders. I recommend participation in normal age-appropriate activities, including PE, camping, sports, and for the patient to monitor his or her own degree of participation. However, it is important that the teacher supervising physical education classes understand the signs and symptoms of exercise intolerance in a child and help the child avoid exercising too intensely. If fatigued, the patient should be allowed to sit out the activity without penalty or guilt. In some situations, adaptive PE and/or avoiding team sports where peer pressure may force the patient to overextend are appropriate options for a child who cannot regulate intensity well. Students should not exercise in extreme temperatures and should replace the fluids and calories used during exercise to decrease metabolic stress. Rarely, rhabdomyolysis may occur, parentheses, heralded by cramps and dark-colored urine, end parentheses, which necessitates hydration in order to avoid kidney injury. A physician letter to the PE teacher or coach can often help them to understand the influence of the disease on physical performance, as well as the safety precautions needed during group physical education classes. Depending upon the severity of the child's mental status, the child can be excused from the California State Fitness testing and any other physical activities that can put him or her at risk for a worsened metabolic status. Supervision by a trained and credentialed physical educator is preferred for children with mitochondrially related functional and dysautonomic disorders. Cofactor therapy. General principles. Many investigators in mitochondrial disease advocate certain cofactors such as coenzyme Q10, riboflavin, and others in the treatment of mitochondrial disease. Although there are no good large-scale double-blind studies to prove efficacy, anecdotal reports indicate that cofactors are beneficial in at least some patients with mitochondrial dysfunction. Opinion ranges widely within the medical community regarding the use of these cofactors, although in practice most mitochondrial specialists do at least see some of these agents, at least in some patients. These same cofactors are increasingly being prescribed and recommended in a wide variety of conditions, such as the elderly, heart disease, retinal disease, migraine, depression, chronic fatigue, etc. My personal opinion is located somewhere in the middle of the range of responses among mitochondrial medicine practitioners. I recommend therapy with selected cofactors in almost all mitochondrial patients. The main reasons is that the cofactors essentially never cause significant harm and they are often beneficial. The major side effect of many cofactors is nausea, which is true for many vitamins and medications. Thus, groups I generally do not recommend cofactors in are 1. Infants with mild to no disease. The nausea vomiting can be worse than the condition. 2. Patients with severe mental retardation, stomach issues, and little functional symptomatology. These patients rarely seem to benefit from this therapy. I am unaware of any known serious side effects of any of the below cofactors despite following their usage in hundreds of patients. However, it must be noticed that very large groups of children have not been subjected to these megadoses of cofactors for a long period of time and potential unknown side effects could occur. Some people get a rapid response from cofactors, but generally it takes 1 to 3 months to notice a response and up to 6 months